So good morning, everybody. I think we'll kick off proceedings now. My name's Mark Gillies. I'm the Director of the Macula Research Group, and welcome to Macular Milestones for 2006. I'd like to read out the welcome to country. We recognise and pay respect to the elders and communities, past, present and emerging, of the lands that the University of Sydney's campuses stand on. For thousands of years, they have shared and exchanged knowledges across innumerable generations for the benefit of all. So today we're talking about advanced macular degeneration, which is either wet degeneration, which is bleeding, which we've been able to treat for some time now since the vascular endothelial growth factors or VEGF inhibitors came out. But there's refinements to that aimed at improving the durability of these treatments so that they last much longer, to reduce the treatment burden, because sometimes people have to have 4 weekly injections for the rest of their life. That's not common. Many people get out to an injection every 3 months, but we're trying to sort of reduce that further so that you can just have one injection of a gene therapy, or maybe an injection once a year of a tyrosine kinase inhibitor. More on that in my presentation. The other type of advanced macular degeneration, of course, is dry macular degeneration, where you get areas of atrophic macula where the photoreceptors disappear. And if they affect the centre, then obviously that affects central vision. Currently, the complement inhibitors are the first treatment for that. They will soon be made available on through the Australian government. They're certainly a very solid first step, but they only slow the progression of the disease. They certainly don't improve vision, and they don't even stop it. They just slow it down by about 30% in the first year, and maybe up to 50% if you persist with treatment. But you need to give these injections every 6 weeks, and there's a significant side effect profile. So we're looking to improve that. Matt Simunovic will be talking about a new bionic device, an artificial retina, which is placed under the macula in people with atrophy, which has recently been developed and may become available soon. And then Dario Protti will be talking about optogenetics. Don't pay much attention to the title. That may not be entirely what he's talking about. Optogenetics, which is a way of making the retina sense light even when the photoreceptors have died. So this is Matt Simunovic, who's a professor here at the SASI Institute, and he's also a vitreoretinal surgeon. He's not here, so he's recorded his talk. I hope it gets through. That's him smiling down there at the bottom.
Good morning. I apologise for not being able to present in person. I'm currently in the USA at the American Ophthalmological Society meeting, but it's a pleasure nevertheless to present on the PRIMA electronic retinal implant, and specifically I'll be talking about the restoration of macular function in patients with geographic atrophy and the not too distant future with inherited forms of macular and retinal degeneration with this implant. Treatments for macular degeneration and macular disease have come a long way over the last 2 decades, yet there's no means of restoring macular function to people who've lost their central light detecting cells or photoreceptors. One possible means of restoring macular function in the future is the PRIMA subretinal electronic or bionic retinal implant. It's shown at the top right. It consists of a camera which is mounted on a pair of glasses. This camera connects to a pocket processor, which at present is worn on the patient's belt. In the future, there are prototypes which are all housed within the spectacle frames. This camera then projects an image onto the implant itself, which is placed surgically underneath the retina, which is shown on the top right. The light that's projected onto the retina is infrared light, so the peripheral retina in patients with macular degeneration cannot detect this light. However, the device itself is both powered by this light, and it also provides an image which is captured by the device. It produces an electrical charge, and this charge is passed to the surviving retinal cells, which normally convey information from the retina to the parts of the brain involved in vision. It represents a paradigm shift in bionic retinas insofar that it doesn't require an external power source which is linked via a ribbon or an electrical wire. It's powered completely by the infrared light which is projected onto the device and functions pretty much like a solar cell in many respects. So what does this device itself consist of? Well, it's a small chip. It's 2 by 2 millimeters in its horizontal and vertical extent. It's very thin. It's only 3/100ths of a millimeter thick. And within the 2 by 2 millimeter chip, there are 378 microelectrodes or pixels which stimulate the surviving retinal cells within the macula. The placement of the device I'll show in subsequent slides, but it's following on from a micro keyhole operation called a pars plana vitrectomy, in which the vitreous gel, which fills most of the eye, is removed. It's then placed underneath the retina after a small cut or incision is made in the retina. As I said in the preceding slide, the image of the world is captured by the smart glasses that the patient wears, and it's projected using near infrared light at 880 nanometers. And this light powers the device and also provides an image. One thing that's unique to this device compared to preceding or earlier generation bionic retinas is that it features a zoom function. The pocket processor itself transmits the processed images to the glasses, and it's possible to adjust certain features of the image in the same way that a computer monitor or a TV can be adjusted, things such as contrast brightness, as well as the scale or size, as I referred to earlier. This is the surgical implantation procedure, which occurs following a pars plana vitrectomy, a micro keyhole operation to remove the vitreous inside the eye. Here I'm performing a subretinal injection, raising a small bleb underneath the nerve cells of the retina. I next use a heating probe, a diathermy probe, to mark out a 3 millimeter incision site, which I open with a small pair of intraocular scissors. This incision is 3 millimeters large. The next step of the procedure is to further separate the neural retina, that is the nerve cells, from the underlying layer, that is the retinal pigment epithelium. This is one of the more delicate parts of the operation. We need to clear a pathway to permit the passage of the device from the retinotomy or the incision, which we've created in the neural retina, to the desired location for placement of this device. In this patient in whom I'm implanting the PRIMA implant, we're targeting an area to the top part of the macula, which is seen in the bottom half of the screen here. Once we've satisfactorily separated the neural retina from the underlying layer, it's next time to implant the device itself, which is inserted via this plastic injector. I'm placing the plastic injector underneath the neural retina, delicately lifting it up with a silicon tip cannula. Here, the device, the PRIMA device, is emerging from the injector itself. You can see the device quite clearly in a moment because it's very reflective. It's quite shiny underneath the retina. You can see it there. It's implanted close to the desired location, but we have to inject some fluid called the fluorooctane or heavy liquid to compress the retina and stabilize both the retina as well as the device itself as we gently move it from a more peripheral location close to where the incision has been made in the retina to a more central location within the macula in this patient. Once the device is quite central and we're happy with the position, we then remove the heavy liquid and remove all of the fluid from the eye, and then it's time to place what is called the tamponade into the eye. Tamponade acts as an internal bandage and allows healing. The tamponades that are principally used are either a gas which is absorbed by the eye or an oil which needs to be removed after around 3 to 4 weeks following the initial. Now these are some images of the device 1 day following implantation. At the top we can see some OCT or optical coherence tomography scans of the implant. It's highly reflective. You can see it here underneath the retina. It's in an appropriate position. The bottom you can see a fundus photograph. So this is an image of the retina, a wide field image demonstrating the position of the implant within the central area of the macula in this patient. So on to the PRIMA study, which was the pivotal trial exploring the efficacy of this device in patients with geographic atrophy, which is the most advanced form of dry macular degeneration. This was an open label trial, that is to say that the patients and the doctors knew what the treatment was. It was not randomized, and the trial occurred across 17 different European sites, both on the continent and in the UK. It was prospectively registered. A total of 38 patients were recruited onto the trial. They were all over 60 years of age. On average, they were 79 years of age. They all had poor visual acuity, so it corresponded to legal blindness in most countries, 696. The primary endpoint of the trial was change in visual acuity, that is the ability to read a letter chart at 12 months following implantation. Secondary outcomes included functional vision, such as the ability to do activities of daily living, such as read letters, as well as the safety of the device. In terms of the surgical experience in the trial, all 38 implantations were completed successfully. The majority of them were performed under general anesthetic, that is, with patients asleep. Most of the patients at the end of surgery had gas bubbles or air bubbles injected into the eye to act as an internal bandage. 11 of the patients had oil injected into the eye to act as a tamponade or internal bandage. These patients required oil removal as a second procedure. There were no cases of intraocular infection, nor were there any cases of uncontrolled retina. So how did patients fare in terms of vision? Well, over 3/4 of patients were able to read letters which were half the size compared to the size of letters they could read on a letter chart prior to implantation. In terms of the average improvement in vision, it was a 5-line improvement on a standardized letter chart. This corresponds to seeing letters which were around 3 times smaller prior to implantation. The best performing patient was able to see 12 lines lower on a standardized letter chart. This means that they were able to see letters which were 16 times smaller compared to their pre-implantation vision. It was reported that there was an integration between the prosthetic vision offered by the implanted device and the peripheral vision. That is to say that there was, as anticipated, no interference between the prosthetic vision and the natural peripheral vision. In terms of functional vision, patients were able to identify shapes and patterns. Some patients were able to read their own mail using the device. It's important to note the patients had to undergo structured rehabilitation in order to learn how to use the vision provided via the device. In terms of adverse events, there were no cases of migration or mechanical failure of the device. As I mentioned earlier, there were no cases of infections. During the surgery, 7 of the patients had small defects in the retina, which were noted. These were treated at the time and did not cause any problems. Some patients had slight elevations of pressure in the eye following surgery. This is not uncommon following vitrectomy. Some patients, as would be anticipated given the surgical nature of the implantation process, had small bleeds underneath the macula, but these adverse events were all deemed mild and they were manageable within the context of postoperative care or intraoperative care. In terms of future directions, as I alluded to earlier, We're performing the PRIMA trial, which seeks to explore the benefits of the PRIMA device in patients with inherited forms of macular and retinal degeneration. We're currently recruiting patients onto this trial at Safeside Institute and at Sydney Eye Hospital. The contact of my research orthoptist, Catherine Lee, appears at the bottom of this slide. Please ask Cami, who's here today, for the details if you or a relative or friend might be interested in this trial. So in summary, we're seeing that the PRIMA study represents the first demonstration of central visual acuity gains with a subretinal bionic implant in patients with geographic atrophy. We saw the clinically meaningful improvements in vision occurred in the study with preservation of peripheral vision with no long-term device-related safety concerns. It's anticipated that the primary implant will receive a CE mark in Europe in late 2026. And finally, the next chapter is the PRIMA study, which we're leading here in Australia. We've recruited the first patients onto the trial here at Sydney Eye Hospital and Safeside Institute. This trial is investigating the efficacy of the primary implant in patients with inherited forms of macular and retinal degeneration. Thank you very much.
All right, thanks, Matt. And we have time for discussion. If you have any questions about that, we can talk about that at the end of the lectures. I omitted to read out the housekeeping matters. The toilets are located to the left of the stage. The lift is beyond the foyer there on the right. The balcony is closed and strictly off limits. In case of fire, exit through the doors behind you and go downstairs. So the next speaker is Dario Protti, who is a scientist at the University of Sydney, who's done many years of excellent work on neuroscience and particularly with respect to the retina. Thanks, Dario.
Thank you very much, Mark. And thank you very much for the opportunity to come and talk about some of the work that we've been doing mainly in collaboration with Matthew Simunovic and Lei Kun To. Today, I'm going to tell you a bit about some of our efforts that we've been doing to restore function to the blind. This is all work on animal models, no humans, and I'm not a clinician. So I'm going to tell you a bit about our approach and some of the challenges that we've been having. Now, to understand our research, first we need to have a look at what happens when the retina stops working. Millions of people worldwide every year lose their sight because the photoreceptors, the light-sensitive cells at the back of the eye, mainly die or become non-functional. And the silver lining of this is that the rest of the retina often survives and remains connected to the brain. But this comes with some trade-off that unfortunately there is some anatomical remodeling in the retina, and the neurons that are lacking the input from photoreceptors and basically light input start to develop some aberrant activity, and there is an increase in background noise. So essentially, the retina starts firing these chaotic and random signals, and that's a bit of a problem, right? And that's what I'm going to tell you a bit about today. Now, to restore vision, there are several different approaches currently being used. As we've seen, Matt told us about prosthetic devices. That's been around for quite some time. And basically, we know the experience of the cochlear implants that has been very successful. Therefore, there is quite a bit of interest in using a similar approach. There are also stem cell transplants and gene therapy. We are using a technique called optogenetics. And this is a very powerful technique in which we inject a virus in the eye. This virus encodes for a photosensitive protein, and it transfects some of the surviving cells. So what we do is basically we render some of the surviving cells in the retina photosensitive. They become sensitive to light. And the ultimate goal of our research is quite simple but ambitious. So we want to bypass the dead photoreceptors and use these cells that have been made photosensitive to carry signals from the retina to the brain, okay? Now, the way we do this is we use an animal model of blindness that has been developed here at the Safe Sight Institute. We use the iCreate DTA176 mouse. And in this mouse, the rod and cone photoreceptors die. So in 3 or 4 weeks of postnatal age, these photoreceptors die and the animals become blind. So what we do is we inject the eye of these blind mice with a virus that will express a photosensitive protein. We allow some time for this virus to express, and then we remove the retina and we place it on a device called a multi-electrode array, and we record the activity of the surviving cells, in this case, the ganglion cells, which are the cells that carry signals from the retina to the rest of the eye, right? To do this, we use this device device that you can see here. This is a multi-electrode array, and this shows the setup that we use. We do electrical recordings of the activity of the cells, okay? And they look something like this. So what we can see here, this device has 60 electrodes, and each of these electrodes can pick the activity of anything between 1 and 8 or 10 neurons, okay? So what we see here, all these horizontal lines that you see here are recordings from one individual channel, and what you see, the vertical lines are the signals sent from the retina to the brain. So these are called action potentials or spikes. And what we see here are small pulses of light that we deliver to a retina. And you can see that when we deliver these pulses, there is an increase in activity in a number of retinal ganglion cells. These are the responses that we record. So we correlate the signals from the retinal cells with the stimulation that we apply. And our goal is to find opsins, photosensitive proteins, that are sensitive in a light range similar to the one that we are normally exposed, ambient light, okay? Now, I know it's only Monday and it's not even noon, but I would like to take you for a few minutes to the pub in a figurative way, and to understand what happens in the blind retina. Let's imagine a conversation in a very noisy environment in the pub. So if you're having a conversation when there is a lot of background noise, not even shouting sometimes can help you communicate. However, when the noise is reduced, even a whisper can be heard clearly, right? This is an analogy to what happens in the blind retina. The blind retina is the equivalent of a very noisy pub with lots and lots of noises. And therefore, if there is a real signal, that signal cannot be distinguished very well from the noise. That's what I'm going to show you now. Here we can see recordings of the electrical activity of a normal retina, what we call wild type. And you can see these small vertical bars that appear there are the action potentials. And I'm showing to you 2 representative neurons. Now I'm going to show you what the blind retina looks like. And you can see there is much more activity, many more action potentials there. And they often come in this bursty manner, right? So there is a very short train of action potentials happening, as you can see there, right? So these aberrant activity, this hyperactivity, typically hampers signals from the retina to the rest of the brain, right? Now, I told you our approach is to use this optogenetic technique. We inject the photosensitive proteins there, or the virus that will express a protein. And this is very good. These viruses can render a blind retina photosensitive. I'm showing to you first here responses. These very short pulses that we see here are light stimuli that we deliver. And we see in a normal retina that when we deliver these light pulses, then the retina fires action potentials. It's like the equivalent of sending signals from the retina to the brain, right? Now, we see that the same happens in the blind retina. When we apply the light pulses, the blind retina also fires action potential. But now in this case, the signals are buried in a sea of noise, right? So what we see is that these horizontal lines are pretty flat. However, in the case of the blind retina, when the signals happen in response to stimulation, there is a lot of background noise, right? So the equivalent of the noisy pub that doesn't allow us to hear very well. So the way, we have some ways to deal with this, and we can use some drugs that can lower that background activity. So it's like pressing a mute button and all the noise goes down and disappears, right? So we're using one drug called MFA that basically it lowers the communication between cells in the retina. And when we look at this spontaneous activity, there are many things that we can quantify. One is the spontaneous frequency, the other one is the frequency of burst, and the other one is the number of spikes per burst. And what we see is that in the blind animal, these values are pretty high. And when we apply this drug MFA, the values go down, all right, significantly, all the values. And what happens with these same 3 neurons that we could see here when we apply MFA? Well, they continue responding to light stimulation, but now it's in a very quiet background, all right? So this is telling us that we are reducing the noise. This is fantastic. Now, this is not telling us very much whether the signal becomes more detectable, right? Now, if we want to look at that, so these metrics that I showed you are telling us all the spontaneous activity goes down. But what does it mean for the brain? Now, to understand this, we can borrow a couple of metrics from engineering. We can look at signal detection theory and ideal observer analysis and use some of the metrics that they use there. And I'm going to show you an example. We will be quantifying 3 different metrics. One is called detectability. The name says it all, how detectable a signal is. The other one is called receiver operating characteristic, area under the curve. And this has to do with an ideal observer or the equivalent of a downstream neuron can characterize an event as either originating from stimulation or as a spontaneous event, right? And the other one is signal to noise ratio, which is how much the signal stands out with respect to the noise. And what I'm going to show you now is simply an animation where you can see that when there is a lot of noise, and this noise overlaps with the signal, it becomes very difficult to distinguish them. Now we have here the 3 metrics that I mentioned, ROC, D prime, and signal to noise ratio. And I only want to show you what happens when we reduce the noise. This is the variance of the noise. So how much noise is there, right? And I want you to pay attention what happens with these 2 distributions and these values. Don't look at the exact numbers, but basically what happens when I reduce the noise basically, these two curves become more separated, right? Now we can distinguish them very well, and the values go up, all right? So now we're going to use these quantification techniques to look at what happens when we apply MFA to the retina. And back to the presentation. When we look at detectability, D prime, we see that in control conditions in the blind retina, the value hovers around 0.5. So this shows the range of values and how clearly detectable they are. And 0.5 is weak detectability. So when we apply MFA, what we see is that all these values go significantly up, right? So essentially, MFA pushes detectability above a functionally critical threshold. When we look at receiver operating characteristic area under the curve, we also see that the values are around 0.6, and this is very close to chance. So this is like a probability. 0.5 is chance, 0.6 is just above chance. When we apply MFA, these values go considerably higher. It's significantly different. And so that means that MFA values yield robust gains in classification performance. This means a downstream neuron can classify this as a signal in the presence of MFA much more than in control conditions. And finally, when we look at signal-to-noise ratio, we see that in control conditions, the values are very low, around 1. And when we apply MFA, they increase significantly. Oh, sorry, I missed that. I went back. Signal-to-noise ratio, when we apply MFA, we increase this value significantly. So we go from the very noisy path to the quiet path where communication becomes clear and there is a significant increase in signal fidelity. So essentially, number one, we validated the DTA 176 as an animal model of retina degeneration. So similar to other models like RD1 or RD10, we see that this mouse model displays aberrant spontaneous activity, this hyperactivity. We showed that background noise is a barrier to restoring sight, but we also showed that by using drugs like MFA, we can reduce the noise and enhance signal clarity. So overall, what we are trying to show is that optogenetics alone might not be enough to restore sight, but when it is combined with pharmacological therapies that can reduce spontaneous activity, it could be key to restore sight to the blind. So I'm going to finish with this. Finally, I would like to acknowledge my collaborators in my lab, Sam Fifield-Smith and Tom Kair, and then at the Safe Sight Institute, Lei Kunto and Matt Simunovic, in Basel, Mohamed Khani, and funding from NHMRC and MDFA. So happy to answer any questions. I hope we're on time. Yeah, all right, okay, thank you.
So yes, optogenetics is one of these ways that we may be able to get people who've lost their photoreceptors to see again, but nobody actually knows yet what they will see. There's a lot of painstaking research and development goes into this. It's been going on for a while, and there's probably a few more years left in it until it comes to the clinic. But there are some initial clinical trials going on with optogenetics. Now we come to, that's Dario. Here I am, this is me. So now I'm talking about mainly the latest treatments for wet macular degeneration. In this space, so far we've had the VEGF inhibitors, and we had like Eylea and Lucentis were the main drugs. Now, the last couple of years, the so-called second generation of VEGF inhibitors have come out. And one of these is faricimab, which we'll talk about, which has an antibody that attacks two things, it blocks two things, not just one thing, not just VEGF, but also Ang2. And we also have high dose of aflibercept. So it used to be 2 milligrams, now it's 8 milligrams. And our research with the Fight Retina Blindness Project has found that these drugs they are stronger, they do more likely to inactivate the neovascular lesions that are invading the retina. And in general, they will, if you switch a patient to these drugs, within a year, you can generally get the treatment interval out by an average of 2 to 3 weeks. So it's not amazing, but it is certainly an improvement. And the new drugs that we'll talk about is gene therapy and TKIs, or tyrosine kinase inhibitors. So with wet macular degeneration, just to a little bit background, the macula is invaded by abnormal blood vessels growing from its blood supply underneath it through the membrane that separates them into the subretinal space. And here they bleed and cause scarring, and that's how you get irreversible loss of vision. So the VEGF inhibitors, and that's all the approach we have, VEGF inhibitors stop these blood vessels growing, and they stop them leaking, they stop them bleeding. So they stabilize the situation and often will lead to improvements in vision if there's a lot of swelling, which you can usually completely reverse with a few injections. I did these slides through AI. That is not what a needle looks like. A needle is basically like what you stick into the skin. If you're doing an injection into your skin, it's just thinner, but it just goes straight into the eye, 4 millimeters back from the junction of the clear part and the white part. VEGF injections are highly effective. They work in about 90% of people, but they do need to be given regularly. And always for VEGF inhibition, it's a lifelong process. So I tell my patients when we start treatment, if you see me in the street, you should run, because I'm going to give you an injection in your eye every time I see you until one of us dies. But these high injection burdens obviously is very expensive, and it's a burden on patients and the people who care for them. And so these new treatments aim to reduce that burden. So we will, and at the same time, to sustain vision and provide longer-term control. So as I said, the new agents are aflibercept 8 milligrams and faricimab. Faricimab also targets this thing called Ang2, angiopoietin 2. That is something that makes the blood vessels leaky and tend to bleed independent of the VEGF. So hopefully stabilizing or blocking that as well will give us a stronger drug, and stronger drugs will last longer. And as I said, if you switch patients, generally you'll be able to extend their treatment interval from, say, on average 8 weekly to 10 or 11 weekly. And many patients these days are getting out to an injection every 4 months, maybe every 5 months. So gene therapy is attractive because what you do is you introduce a gene into the eye, which makes the retina produce aflibercept, the drug that stops the blocks of VEGF and stops the bleeding and the leaking. And if you do this, then those cells will continue to make VEGF forever. The problem with this is we don't know what the off-target effects are, and we don't know what continuous VEGF inhibition will actually result in. It's possible that, for example, it might cause more atrophy, because we know that people who are on the injections do get atrophy, and there's a long controversy which still isn't resolved as to whether the VEGF injections are actually exacerbating the atrophy that also occurs in these patients, And in fact, that's why people on injections will long-term often lose vision because they develop atrophy. So these gene therapies are delivered with viruses, which have been designed to penetrate the retina. They used to had to be injected under the retina, but now they're designing viruses that you can just inject into the jelly like we do with the VEGF inhibitors without the need for an operation. And these it gets into the cells and makes them produce these aflibercept in the eye forever. It's a one-time procedure. If it is a subretinal injection, such as Matt was talking about, that has to be done in an operating theatre. But as I say, they're trying to engineer these viruses now so that they can just be injected into the vitreous. And it's not actually gene editing. You're not actually cutting genes out. You're just adding a gene in there to make the VEGF inhibitor. Where are we with these things? Well, we're certainly in clinical trials. Some have cleared the phase 1, phase 2 trials, and they do have fairly encouraging results out to 1 to 2 years. It's not complete inhibition, so mostly patients are getting topped up with an injection once or twice a year on average. Some people don't need that, but some people do. The phase 3 studies are just getting started now, and we should have the results for those in a couple of years, and maybe we'll hit the clinic in 3 to 5 years. So that's the idea. You just don't have to have as many injections, and perhaps you don't need any injections at all after this so-called one and done treatment. So the next advance, and these drugs are also in clinical trials, are these tyrosine kinase inhibitors. And these can be taken as pills in some case or delivered into the eye. The point about the tyrosine kinase inhibitors is they're just small molecules, and so they can be formulated in gels and this sort of thing, which lasts for up to a year. So you might just be having a yearly injection of a tyrosine kinase inhibitor compared with, 3 or 4 monthly, which is about the best we can get to at the moment. The tyrosine kinase inhibitors they work on the VEGF receptor, but not in the normal way. So this is the receptor here, that purple thing, which is sticking into a cell, and the beaded ends on the end, that's where the VEGF binds. So all the current therapies will bind to this beaded end and stop VEGF binding. These tyrosine kinase inhibitors inhibit the intracellular part of the receptor, which is an enzyme called tyrosine kinase, which is how the receptor turns on the pathways in the cell to make it leaky and bleedy. And so it blocks these cells in the receptor inside the cell. And as I say, it can block all the VEGF receptors. And because it's a small molecule and very durable, it can last for at least a year, sometimes longer. There are some that are taken orally. The other thing is given by injection as usual. There's a list of the oral TKIs that are under development now, and then the local intravitreal ones. These drugs are more advanced in gene therapy now. In fact, this is how the clinical trial program goes. You get the preclinical data, such as we've been hearing from Dario, where you do these experiments in laboratory animals. And then the phase 1 is usually everyone gets it and you see if it's safe or not. Then the phase 2 is the first go, where you might have maybe 80 patients per group. And it's the first time that you actually look to see whether it's actually working or not. And then the phase 3 is the one that's designed to get through the Food and Drug Administration in America, which will get it registration and governments will pay for it, and it gets rolled out commercially. And these TKIs, many of these TKIs are now in phase 3 studies, so we should be seeing them sometime in the next couple of years. So that's just a comparison, but basically they're both going for extended durability. In restoring vision now and geographic atrophy. So we've heard 2 approaches now. There's a retina with a big patch of atrophy where the inner retina is still there, but the photoreceptors are all dead. So it can't actually sense light. So Matt Simunovic told us about the new bionic eye development, which is very encouraging. But these patients, even though they got a 5-line improvement, it's still on a very low base. So they're still like about 5 lines off getting a driving license. And they have some restriction of the visual field too. So definitely it's an advance. And I think many people would be happy with it, but it doesn't give you perfect vision. So the other developments in atrophy, well, there's new developments in cell therapy, which has been the holy grail for many years. And then the other developments, apart from what Matt talked about and Dario talked about, is in other agents that can effectively slow the expansion of the atrophy. It doesn't improve vision, it doesn't stop it, it just slows it down, but they can be given much more effectively rather than 6 weekly injections the rest of your life. So the cell therapy, this is where you actually put the retinal pigment epithelial cells, which is the base of the retina, and that's what goes missing, and then the photoreceptors follow them. Cell therapy is what everyone's been looking for a long time, stem cell therapy. So this is a replacement of the RPE. And the good news is that they have got these studies into clinical trials now. So there is the OperaGen, which is Roche Genentech, which the phase 1 study, the 36-month data showed that there was some improvement in vision in these eyes after having retinal pigment epithelial cell transplants. The thing about the RPE transplants is that it's better to do them before the photoreceptors have gone. So you would want to intervene early. You can usually see when it's starting to happen, you can see the retina start to sink down. And they're the ones that you'd want to put it in before they lost too much vision, because then you may maintain it. It may not be as effective for people with established atrophy. But these studies are now in phase 1 and phase 2 studies, which is encouraging because we've talked about it for 20 years. And this is the first time that we've actually got these things in the clinical trials. So definitely progress is being made there. And then gene therapy is also being applied to atrophy. And once again, this is not a therapy that was going to improve anyone's vision if they've already lost it. It will just slow it down, but it might be a one and done rather than 6 weekly injections that you see with pegcetacoplan or Syfovre, which we currently have now. And it may do that more safely than the other treatments. And these studies are also now in clinical trials. And at the clinical trials unit here at the Safe Sight Institute / Eye Hospital, we have about 3 studies going on at the moment for atrophy. Because of the unique Australian tax laws for drug development and clinical trials, Australia is probably the place in the world where people want to do these early phase clinical trials. So we always have a lot of these trials in development, and we're doing them. So people with atrophy, especially who haven't gone to the centre yet, we're very happy to consider them for clinical trials. And finally, there's the PRIMA implant, which is what Matt just talked about then. So basically, this is a field where, as much as cancer, which is the other active field, it's one of the most active fields in biomedical research because the benefits are very, very clear. Everyone understands preventing loss of vision or improving vision if people have lost it. There's a huge amount of money involved, and there are scores of companies who are developing products, improved products for the treatment of wet macular degeneration to reduce the treatment load, and products which will slow the spread of atrophy once it occurs, and even products which may prevent atrophy from forming in the first place. So definitely things are coming through, and they'll continue to come through in the next 5 years, and there's a lot of hope for people with advanced macular degeneration. So now we could finish with some questions for Mark, Dario, or Matt, if you had anything on the PRIMA implant, because I think we could probably think of an answer, or we'll take it on notice if we can't. Anyone have any comments or questions? Yes.
That's not here. That's for people obviously with just geographic atrophy. Is there a risk of, obviously interference with neovascular AMD?
Do they become neovascularized?
Yeah, or is there an increased risk of?
Well, that's something they'll probably. It's only been it's only early days, but it's a device. So I'm not sure to what extent they need to do a large clinical trial. It sounds like we're doing one here at the eye hospital. Yes, there's always, anytime you play around with the macula, there is always a risk that you'll get neovascularization, and that occurs with, that's the rate of wet macular degeneration occurring in eyes who are receiving the current treatments for atrophy actually goes up, goes from about 5 to 10% over 2 years. That's an issue. It's always an issue. And that will come out if they do with the ongoing clinical trials program, but also with the observational stuff, because with the Fight Retina Blindness Registry, our outcome registry, we track atrophy, and we'll be tracking the outcomes of that. So yes, it's certainly a possibility, but even if it does, you can treat that. So the VEGF inhibitors and these new VEGF inhibitors are probably going to be better than the old ones. It's something that it's not going to stop people, but yes, it certainly could be an issue. Yes, sir.
Is there any data on, say, if this PRIMA implant, there's something goes wrong, or perhaps a better one is invented or developed, can it be removed as easily as it's put in and be replaced or repaired if need arises?
Well, that's a really good question because that would probably be difficult. And certainly, so if you had some of the older bionic implants, then it would make it very difficult to do this one. But this is a pretty tiny device, actually. They'll see if it becomes encapsulated with time, but that's always an issue with these things. But I'm not certain that there's anything in the pipeline that is sort of about to be released that I've heard about that is going to replace the PRIMA implant. They are getting, for a bionic implant, they are getting very, very good results. And in terms of sort of disruption of the local anatomy, it's much less disruptive than the bionic implants we've had in the past. The reason it's so successful, the reason it's such an advance is it has a very high density of individual little receptors. I think he said it was is it a 12 by 12 or something like that? Like the previous bionic implants were sort of like 4 by 4 or 6 by 6, maybe 8 by 8, but they had quite a low density, so you weren't going to get particularly good vision. This one's got a much higher density of individual little receptors in it, so you do need that to get higher acuity vision. Yes, ma'am.
With the PRIMA implant as well, I wanted to ask, I believe Matt mentioned that patients had to undergo visual training to learn how to use the implant. What would that look like for them? Is that done with a special type of physiotherapist of some sort, with an ophthalmologist?
No, it might be a physio and it won't be an ophthalmologist, I wouldn't think. No, they'll have special people who are able to do that. I'm not exactly sure. Well, certainly you've got to operate the device for a start. So it has a zoom function. The zoom function, I think, is one of the reasons they're getting this high acuity vision of these big improvements, because you can zoom in on something, but don't forget, when you zoom in, you lose field. So you might be zooming in just seeing one letter at a time. So that's something they'd have to be able to use. And maybe and you'll also have like a small area of central vision. It's only 2 millimeters, a small area of central vision, and around that's going to be a little blind spot, and then you have all your peripheral vision. So the people who've done this will have a lot of experience from previous patients about what issues they've come up against and how they've solved it. It's not necessarily straightforward. You wake up and you'll be able to see. I think there will be a degree of training involved in how to get the best out of what you've got in the eye. We've got time for one more question. Oh, Maria.
I don't have a question, but I just wanted to add to the last question. I know a little bit about the study in terms of the rehabilitation, and currently it's the sponsor who's providing that rehabilitation directly. So I don't believe that it's like a physiotherapist or somebody. So currently it's the sponsor, and I suspect that once they establish what's required for the rehabilitation, that they'll be able to then get orthoptists or somebody like that to provide it.
Are we doing that trial, Maria?
Yes, so, well, Matt is, yeah.
How many patients?
Only one
We're only doing one.
currently one enrolled.
But is there a target?
We don't know the target.
Okay. All right. Well, thanks everyone for coming. See you next year. And we can have a little chat over the sushi and the delicious sandwiches and all that up the back.